Good everyone. On behalf of Juventus Healthcare and all the learners worldwide, I take the privilege of welcoming Sir Dr. P.C. Mahapatra Sir on the eve of second anniversary of E-Gurukul. What we are very pleased is that Sir started this program, this initiative on Teachers' Day exactly 2 years back with a very noble objective and with to disseminate information, disseminate science through his vision and his perspective. And it is very apt when we share the screen, which applies as a teacher's purpose is not to create students in his own image, but to develop students who can create their own image. And with this objective, Sir has initiated this program. We are very humbled to be associated, Sir, with you for the last 2 years, and we would be continuously associated with this program, so that people can learn. Now, one more definition of a teacher, what we found was an excellent kind of elements of a teacher. It says tellurium, actinium, hydrogen, and erbium, and there are unique properties like a good conductor of energy. It required a level of accuracy, spontaneously and is explosive when concentrated, and is a bit soft but also firm and radiates lights. This is how a teacher can be defined through elements. And we are very pleased to share with you that Sir has actually all these elements which are required to be an excellent teacher. So, Sir, sincere, what do you say, tribute from all of us to the teacher within you and to you. And we request you, sir, to take over the program. It has been a fantastic association for Juventus. Thank you so much. And I hand over the session on this Teachers' Day to you. Thank you.
Thank you very much, the team Juventus under the leadership of Alad Mahajan. The concept was designed by you exactly 2 years before. And on the Teachers' Day, I remember 2020, we started the program with a theme that is a surgical options in obstetrics and gynecology, the tips and tricks. I couldn't think of this, that by this time 27 episodes are over. And again, we are gathered here today for celebrating the Teachers' Day as well as academic celebration and the second anniversary of E-Gurukul program by Juventus. Well, I thought it will be the end of the session, but your team has really inspired me that it is the beginning of the session. Again, you start a second session after that, and we'll continue this E-Gurukul program for the benefit of the students, the benefit of the gynecologists across the country and abroad, as well as the benefit of myself, who will also benefited by giving this E-Gurukul series by that. Well, I again congratulate all of you, my viewers, and my gynecologists, my students, my colleagues, and everybody those who are viewing this E-Gurukul program. Well, again, thank you, Juventus, for giving this platform to all of us and for the upgradation of the science. And I think the surgical skill transfer and solving clinical dilemmas, the tips and tricks have been over, subjecting the focusing on each and every aspect, starting from cesarean section and ending with the malignancy. Now, today is something new. Today is the second anniversary, and really a very, very auspicious occasion for the teachers as well as for the students to introspect themselves, whether they are fit to be a teacher or they're ardent learners for that, and find out what are the defects that are there within it. I bring greetings from the place of Lord Jagannath. And again, this particular day, on my behalf, on behalf of all the teachers, medical teachers and teachers in gynecology, my special tribute to my teachers, my grand teachers, and the family of teachers on this auspicious occasion and second anniversary of E-Gurukul. Today we are celebrating under your platform academic partnership for that. Well, I decided that today is something special. The chapter on surgical skill transfer has been closed. The E-Gurukul series will start a new chapter. The obstetrics and gynecology from basic to advanced, and solving clinical dilemmas. That will be my focus of attention in the next episodes. Continuing, I don't know how many episodes we'll do it subsequently for that. Till you people tell that I will stop, then only that is the end of the session for that. But today is something different. And today is, I thought that this is the day of introspection of the teachers as well as students. And therefore, I changed my topic today and have a frank confession of myself, where from I came, how I became a teacher, and what I did, and what is my future for that. And believe me, I have done more mistakes in life than anybody else. For the last 46 years of my association with gynecology and as a teacher, I do admit and confess what are the mistakes I have done. And therefore, that could be a learning for all of you, that you don't do the same mistake, you gain from this mistake and develop there. And therefore, my topic today is a confession for that. Well, therefore, I've divided this particular session into three main aspects. First, let me introduce myself again. The unseen thing, or something which many people do not know about journey of my own life. It's a very ordinary journey of my own life, and God has helped me starting from my initiation of the career till date, and helping me also today till my last breath. I wish God will have a divine blessing on me for this particular program, as well as for the benefit of the patients for that. The first topic, I will deal with the journey of my life. Second, I'll just focus attention on this particular auspicious day, what is the relationship between the teachers and students. There's something unique, and I will focus on the need of the student versus mood of the teachers. This is my second portion of my talk. And the last, I will conclude with mistakes in my life and what are the lessons learned. And these are all real life clinical scenario and situation analysis I will present before you. And that is the end of that particular day, Teachers' Day 2022. Well, with the due submission, journey of my life. I was born way back in 1956 to a very lower middle class family, to a family of a teacher, school teacher. My father was a school teacher. He was an extraordinary school teacher with the President's Award school teacher. Believe me, when I asked him, you are well educated with the tussle. I know how difficult it is at those times to be educated coming from a rural village and without any financial assistance. He graduated pre-independence. And after the independence, he got a very lucrative jobs, but decided that I will be a school teacher. I don't know what is his concept. And my mother was a total illiterate, but having a highest level of common sense, a vision. I think my father is an educated person, but without vision. But mother is full of vision and common sense for that. And I've got 6 sisters and only 1 brother. That means me, 1 son. I don't have any brother. 3 sisters and 3 sisters, my senior elders, and 3 sisters younger, and I am in between. Most probably my father wanted a son, and that's why they tried 3 times, and then they became successful in giving birth to the 4th child, and I was being born for that. Then again I told, if you're fulfilled, then they should have stopped it. And that's why they named me as Purnachandra. That means my dream is fulfilled, that your son, I have given birth to a son. I asked them, if your dream is fulfilled, why you again tried for that? Another 3 sisters and another 3 children were being born for that. But however, this is my really the family of mine consisting of 6 sisters and father and mother. Well, we are being taught more about moral values, spiritual influence, and always my mother tells that don't be a great man, be a man rather than a great man. And that I captured that sentence until today. I thought I'll prefer to be a man rather than a great man. I was inspired by my three elder sisters who were brilliant parents and teachers from beginning. Fortunately, I was very lucky to be with the teacher's family, and therefore I was very much inspired for education. I've never felt the differences between the son and daughter in my own family, and hats off to my parents for this. But I still imagine I was brought up amidst deficiency and financial burden. Believe me, I still remember in my early days in schools, in the primary schools, electricity was not there. We have seen electricity, and before electricity also we were being using without electricity. I was just learning and studying for that. And I believe that this is a boon for me. I always believe that no starvation, no growth. And that today I always tell, if you have a plenty, you will suffer. If you have if you have felt this starvation, you will grow and really succeed in life for that. And that is true, which I've experienced for that. As far as the studentship is concerned, I was not a brilliant student. This is a frank confession of mine. I was an either average or less than average student in both in the school and the college career, and devoting more time to the extracurricular activities than studies. But I was keen to become a doctor from beginning. And when doctor has inspired me, when I saw in a district when I was studying the primary school, he was the first MBBS in that area, and he was the only doctor in that area. I was really amazed to see him. He is my idol, and I decided that I'll be a doctor like him. But involved in more in extracurricular activities than studies. And somehow in the pre-medical or pre-engineering courses, pre-professional career, everybody decides for a career. Now the options are plenty. But in those days, the options are very limited. Either a doctor or an engineer or a civil servant or bank employees or a teacher or whatever it may be. And with that, my parents' wish was that I should be a civil servant. But from the beginning, I was not keen for any administrative post for that. I thought I'll be a failure in that line. And I was keen to be a doctor from the beginning. But knowing that my parents may push me into other branches like a civil servants, without their knowledge, I applied for engineering. In the pre-profession at that time, we were being selected by mark basis. And I was the first batch in the medical profession where the entrance was first started. And when the entrance was there, there was uncertainty whether I will get it or not. And therefore, I joined engineering courses. And in Regional Engineering College, Rourkela, now the NIT. And studied for 3 months, have a full ragging in the engineering courses. And when I got selected in the medical curriculum, then I changed from engineering to medical. And somehow I become really happy that I have fulfilled my ambition for that. I was an average student, very low profile, and studied with scholarships amount. I told that, yes, I have seen the financial crunches of my father and the whole large family where everybody has to be educated for that. Now, after that, completing the MBBS, I was interested for higher studies. And from the third year career, I think the subject of gynecology has inspired me. From that time, I wanted that if at all higher studies has to be done, it is only obstetrics and gynecology, nothing else for that. Somehow, I was interested in that. But my father was not very much keen that I should join gynecology. He always tells You are a male doctor, and how you are going for that? He's a school teacher. The basic common sense is that how you are a man, no patients will come to you, female patients will come to you. I just laughed and then said that it's my wish. That's not a problem. And you do not know there are very male gynecologists. They are very popular and proficient in that line for that. And fortunately, by God's blessing, I could get through PG entrance by chance in a premier institute at Vaishya Medical College, Cuttack in Obstetrics Gynaecology, way back in 1980s, 79, 80s. At that time, when I joined there, I didn't know anything in obstetrics and gynecology in comparison to my batchmates. Those who are there, they're more profound, more experienced. So I was very feeling inferior. But I toiled hard, devoting maximum time in labor room, library, and OT, assisting a variety of surgeons committed to profession, experienced pleasures and pains, and successfully completed PG courses. Believe me, in those times, there are no books. Hardly in the library also we find one almirah with 13 books only was there. And somehow, by the grace of God, I don't know what has happened. When I joined the obstetrics and gynecology PG courses, this subject has really attracted me. And then only I was interested for studies. Otherwise, I was not at all interested for medical studies from the MBBS career for that. I started studying during my postgraduates and then afterwards for that. And that is the subject gynecology is responsible for making a magnet out of it. And I was really keen to devote my studies, particularly in that particular subject. Then after completion of my postgraduate, I joined as a specialist in a remote CHC in a tribal area in Odisha, where it was a rule that you have to serve it if you want to have enter into medical college as a teacher faculty, you have to serve there for minimum period of 1 year and then again face another entrance for the medical teaching courses for that. And I had to go there. But from the beginning, I wanted to become a gynecologist. And from the beginning, I wanted to become a teacher in this profession for that. But when I pushed to that, I enjoyed the 3 years peripheral services in the very remote tribal area where you have to walk few kilometers to enter into that area. But when I saw that PHCs, the people are so poor, the tribal, innocent, ignorant. But at the same time, I want to serve them. And at the same time, I want to keep in touch with my surgery. Otherwise, you will forget it. And that's why I'm very keen to start surgery. And in the CSC, nothing was there. I started surgery with the local anesthesia. I remember still the cesarean section, first cesarean section, hysterectomy. I did it with the local anesthesia. And then, in some difficulties, I had to give a spinal anesthesia by myself, giving this ephedrine 15 minutes before and making head up position, not head down position for that, for the possibility of total spinal. I practiced anesthesia, doing routine and emergency surgeries regularly to keep in touch as well as serve the poor and tribal people. And that's why God has also helped me in that. Lot of support and love from the entire area, from political to bureaucratic to medical fields. And I enjoyed the 3 years giving service to people for that. I was very much keen to become a teacher, and that is a stimulus by my father, who was a school teacher. I had a tremendous, because my 3 elder sisters are all in education line and all are lecturers in economics, in home science, and political science. And therefore, I also wanted to become a teacher in the medical field for that. And that stimulus has got from my father and sisters, as well as the profession itself, the subject itself. And then could be selected as a faculty, at that time lecturer, not assistant professor, lecturer in that same alma mater where I have read, the SC Medical College. And inspired by all my then teachers, in 80s, I joined in that college, early 80s, I joined in that college as a lecturer. And I really salute those teachers who had taught me A to Z of gynecology on this particular auspicious day also, and devoted to work and teaching undergraduates and postgraduates. I made it a point that whatever deficit I had in my student career, I will try to fulfill to my students for that. And apart from your own studies and reading, you have to teach undergraduate and postgraduate. Teaching is I felt that by teaching I have learned many things. Because these students have asked questions which I failed to answer. And that is the reason why the teacher become a real teacher by the students also. Students are also responsible. And today in this auspicious day, I salute my students for encouraging me, and not only encouraging, but guiding me also. I've learned something from the students also. I learned a lot from my patients. In a medical curriculum, all of you know that the first teacher is your patients. You learn many things from the patients, from the paramedical staffs, even sisters, even the nurses, even the OT attendant. I have learned from them. And then our own elder brothers and elder sisters, our postgraduate career, I have learned many things from my senior for that. And these and teachers over years. I was very lucky, by choice or by chance, I don't know, but more by chance. I was in SCV Medical College for long years. And 13 years I have served for lecturer, 10 years as an assistant professor, 3 years as an associate professor, and 10 years as a professor. And ultimately, I had to retire this year in 2022, 65 at the age of 65. But I decided that the government has increased the age limit, and I thought that I should take VR, and I took VR 3 years before my tenure in 2018. I thought that let me not block the career of my students, the juniors. If I take VR, 3 posts will be vacant and 3 of my students will be benefited for that. That's the main reason for which I took VR 3 years before my tenure in 2018. And I have not stopped teaching also. I'm continuing my profession in this Prachi Institute for Mother and Child Care, Cuttack, and involved not only in the regular teaching curriculum by the skill development training and regular CMEs, workshops in this institute for that also. But again, and weekend, I'm going to every place to be associated with the different societies, the different colleges for the teaching program of postgraduate. I wish that I'll maintain it till my last breath. And then I thought in the last part, I will devote full of my time to the teaching part along with the treatment. And therefore, I instituted the Prachi Education Foundation and continuing ongoing regular skill development program for gynecologists and various workshops, CMEs, and many more. I'm very happy that till today also, every day I am teaching and I'm learning from them. Not that I'm giving something to them also. Coming to my personal life, I'm married to a only wife, Dr. Jayasri, a gynecologist. And at that time, the profession of obstetrics and gynecology has become so alluring to me. And I'm so attached to my profession that I dreamt to have a family of gynecologists. And that's why my only daughter, Prachi, is a gynecologist. And son-in-law, Siddharth, both are gynecologists. And my dream fulfilled that I'm a family of gynecologists for that. And that's why I thought I'm married to the profession, I'm married to the subject of gynecology for that. And I love my profession more than my family. Apart from my personal life, the technical life, I'm very much happy to be involved in the social life. Even I got a chance and opportunities and request from the various political parties to enter into the political career. I thought I'll not be in the parliament on the assembly. I'll be in the road and serve the poor people in the hospital, giving a treatment as well as teaching students for that. Although I founded two voluntary organizations called Sakha and Janani. One is for the destitute and another for the mental asylum. I think it's a mentally handicapped, challenged ladies who are roaming in the roads and nobody bothers for that. I'm keeping them. And that's my personal satisfaction that I am really doing something for them. The destitutes, which I'm keeping that in the Sakha house and Janani house for that also. I'm very happy to serve in my personal caliber for that. Coming to my life and organizations, how the organizations I was involved in that, apart from being a teacher, various medical organizations I'm attached. And I love Foxy the most. And Foxy, IAG, ISAR, IFFS, IMA, ISOPARB, IMS, Suffolk, FIGO, all these are evolving from Foxy. And this sister organization, I'm part and parcel in forming this organization from the beginning for that. I'm associated with these organizations over years. And somehow I'm very happy to be involved in these academic organizations for that. Could have a chance to head these organizations. And not only associated, I am being involved in various capacities as chairpersons, vice president, and president of this organization, and representative, Indian representative of Suffolk for that. And various national and international forum I was being attached. And this is possible not by my effort, not by my caliber, not by my merit, but it's possible because of blind support from each and every gynecologist across the country and abroad. I salute them, all of them, today in this auspicious organization. These organizations have really given me a lot of opportunities. These organizations have given me a lot of chances to develop my potentialities. And I learned from all the people, those who are there in these organizations. And they are my teachers also, the past presidents of Foxy, and many office bearers of Foxy, Secretary General and all that. I was being influenced by all of them. And really, I'm enriched with all these and attain this particular level. End stage. What is my end stage? I decided that I will work till my till my last breath. I have a passion for teaching and compassion for treatment. And I have a special affinity grooming younger generation. I want to see the younger generation excelling me and grooming the younger generation. If you do not groom, I think your life is incomplete in that respect. But I don't know where is the end out of all these. I want that there should be amalgamation of happiness overall in life for that. That depends on various aspects. How to be happy, that depends on various aspects. But if you ask me, I'll be most happy if my patients are happy. I always pray God, those patients who come to me crying, if they go leaving me smiling, that is the ultimate thing which I've got it, an ultimate happiness which I got it for that. And believe me, everybody has its own philosophy. And I have also this philosophy of happiness, that I'm a very, I think, a narrow vision philosophy, that I'm only bounded to my profession only and society. I think the social work for that, not beyond that. I cannot change the society. I cannot change anything. I have got many felicitation awards and everything for that, but none of these felicitation and awards have really allured me. The only felicitation and award I will be happy if I get an award from my students, if I get an award from my patients. That is the ultimate award for me, an ultimate award of satisfaction. Beyond that, there is no other award which can fulfill me and give me happiness for that. Thank you, my viewers, for the first part, confessing my own life for that. And the second component, the second part, is something related to the student and teacher. The need of the student. What is the need of the student? And with special emphasis on the medical student, with more special emphasis on postgraduate in obstetrics and gynecology. I will just restrict my talk to my subject, obstetrics and gynecology. What is the need of the student? Professional degree. Yes, you need a professional degree. Or a professional competence. You need a professional competence also. The professional degree is responsible for giving you a certification or a credentialing. But professional competence is required for ultimately giving the output and how you deliver it to the society, to your patients. And these two are very, very important for a medical student and a postgraduate student in obstetrics and gynecology for that. And therefore, it's a professional degree or a professional competence or both. I think both are responsible for that. And the need of the hour, therefore, is an ideal teacher is responsible and ardent learner is required also. If these two combinations are there, I think the teaching profession can be fulfilled and the aims of teaching can be really fulfilled if an ideal teacher is there and an ardent learner is there. Now, coming to the spectrum of teaching, because in a teacher's day, we classify the teachers vary according to the different capacities. Teaching preschool, teaching in school, teaching in colleges, and teaching in medical colleges. These are all spectrum of teaching. And this spectrum of teaching are different in different parts for that also. Teaching in a medical college is something different than teaching in a general college, than in the school for that. Maybe the common philosophy is there that you have to inspire the student, but the courses, the types, and the methodology of teaching is completely different for that. Teaching in medicine, again, varies from undergraduates to postgraduates to super specialization. We have seen that undergraduate teaching, the methodology is completely different than the postgraduate teaching and super specialization for that. Now coming to the obstetrics and gynecology. Obstetrics and gynecology, these are some of the dimensions of teaching. The dimensions of teaching, from my own experience as a student, I also found that yes, teaching in obstetrics gynecology, where from you learn. Each place you have to learn, and each place you have to learn something different than the other places. OPD. Yes, people think that we'll just do a surgery and all that we learn. No. OPD, how you deliver the goods, how you deal with the patients, how you talk, how you take the history, how you have the examination, and what are the investigations you suggest, and approach to the patient. This is important. So OPD, you learn a lot. You see a variety of patients in the OPD and you learn a lot. Labor room. In obstetrics and gynecology, I think that labor room is one of the temple where a divinity should be there and time should be ignored. You have to stay days and nights, spend sleepless nights in the labor room to learn, and that will give the spirit of learning for that and the skill of learning in the labor room. Don't ignore that. And of course, OT, surgical part is an important part. OT also, you do be involved in that. And there's what about the general wards? Ward rounds. The general inpatient treatment, you do the treatment. You are not that only recording the vitals like blood pressure and pulse, but in ward rounds, you have lot of things to learn. But an ideal teacher should be there who will teach it in every step, and an ardent learner should be there who will be at the receiving end for that. Starting from the OPD to labor room to OT to ward rounds, everywhere this interaction of the teachers and the students is necessary for that. Sonography and endoscopy has become two hands of obstetrics and gynecology. Now, In my early days, when we were students, sonography was not there. We are mainly depending on the clinical sense for that. But sonography now has evolved in such a way, the imaging science has evolved in such a way that I always tell my students, spend some time every day in the sonography room. Just see and practice this, and you can learn quite a good amount of things. Spend in endoscopy OT. You think the more advanced thing you can learn for that. And seminars, workshops, conferences. I think these are something where you can learn many things for that. And there are stalwarts who are there in the workshops and seminars and conference. And legendary innovators are there, scientists are there, pioneers are there. You not only keep in touch with them, see them, but listen to them. What is their viewpoints with that? And you learn a lot. In seminar also, I always say that the postgraduate should be actively involved in seminar so that not only the speaker in the seminar will speak, these postgraduates present there, they also should participate. And it's not the question of question answer, but they will participate there. That will improve your vocabulary, sense of vocabulary for that. And the postgraduate student should be also a teacher. I've learned from that. During my postgraduate teaching, postgraduate student career, I was teaching undergraduate. I was teaching the junior postgraduate. I think you learn from that. And in emergency, critical situations in emergencies, you have to learn many things for a life-saving. Then, of course, last, I will give to faculty teaching. A theory class is essential for undergraduates, but a theory class is necessary for postgraduates, but not absolutely mandatory. Because it's a very important aspect starting from the day in and day out, entry into the hospital, from the wards to the labor room, to the sonography room, to the OT, to the various activities in the seminar. You can learn many things for that. But of course, the faculty teaching is sometimes necessary, whereas I don't think that theory and practice are completely different. Theory is absolutely essential. It should be a blend between theory and practice, and therefore applied theory is necessary for that. Types of teaching methods. These are various types of teaching methodology. Brainstorming, Delphi technique, direct observation procedures with feedback, lectures. I think I differ in that. Lectures. I was just giving given one lecture on lecturing versus teaching. There is a difference between lecturing versus teaching. You can give a lecture quoting evidences and fantastic oratory capacity. You can give a lecture. But teaching methodology is completely different. I know a teacher can only identify who are the teachers by the talk, because the methodology is completely different, the teaching methodology, than the lecture session for that. The 1 minute preceptorship, peer coaching, problem-based learning, schema activation, schema refinement, simplified procedural hierarchy, complex procedural hierarchy, and snowballing. These are all types of teaching methodology a teacher should know about it. And this is the learning pyramid. Just to have a focus from the National Training Laboratories, Bethel, you get maximum learning average student retention rates by whatever methods. The lecture and reading are minimum 10%. 10% by reading, 20% by audio visual, 30% by demonstration, 50% by discussion, 75% by practice doing, but 90% by teaching others. That's why if you are a student and you want to be a teacher, you teach the undergraduates, you teach your juniors, then only you can have love. Because the average student retention varies as per this learning pyramid for them. Again, this is a very common thing, accepted thing in Bloom's taxonomy. How to complete this? The different phases of 6 different phases in the pyramid you can find out. First, basic is a knowledge. You require a knowledge. Knowledge, there are plenty of, now the high-tech era, technology has given us opportunity to derive knowledge from various sources in this era of technology. Recall of information, discovery, observation, listening, listing, locating, and naming. Then comprehension. After knowledge, you have to comprehend. You have to understand, translate, summarizing, demonstrating, and discussing. After comprehension, the application. Application using and applying knowledge, using problem-solving methods, manipulating, designing, experimenting. Basing on this knowledge or theory and comprehending this theory, you have to apply it. Then the next step comes as an analysis. You analyze, identifying and analyzing meta patterns, organization of ideas, recognizing trends, and then synthesize it by using old concepts to create new ideas. Design and invention, composing, imaging, inferring, modifying, predicting, and combining. And then evaluate yourself. This is very, very important that you have to evaluate yourself every time. Assessing the theories, comparison of ideas, evaluating outcomes, solving, judging, recommending, and rating. And if everything can be done, you are an exceptional student, you are an exceptional teacher for that. This is both essential for teacher and students. Now, what are the changing scenario of teaching today? Acquiring knowledge, as I have already told, from none to plenty. In my days, it was only 12 books in the library where I was just going through that. But now it's a plenty of books, plenty of materials, plenty of literatures, and at the fingertips, you can get everything. So from none to plenty, you have got. The concept is changing. Don't think that the concept is static. There is a changing concepts of various subjects in obstetrics and gynecology. Yesterday's contraindications are today's indication. And therefore, the concept, you must be abrupt with that every time till your last breath. Evolving subspecialties. In our time, we know that initially it was obstetrics and gynecology, and I thought one of the reasons for which obstetrics and gynecology I took it, there is no super specialization. And it is an ultimatum. There is no further reading for that. And now we find there are many subspecialty and super specialty in obstetrics and gynecology also. Branches like infertility, oncology, sonography, fetal medicine, whatnot. More and more subspecialty and target-oriented are there for that also. And the teaching methodology started from chalk to talk to high-tech systems for that. I have passed through every phases of my teaching curriculum, chalk to talk. Majority of my career in the classroom, it is a chalk and duster. And then when the technology has developed, then they came in between the overhead projector. Then they came now the computer. And in all classes now in audiovisual, the classes, more people now, the present generation of teachers are mainly resorting to this high-tech system rather than chalk and duster. I must quote one thing here. I had studied between the students a comparison between chalk and duster and high-tech system, the computer presentations. And took an opinion that 70% of the students wanted chalk and duster. 30% only wanted the presentations in the computer for that. And those 30% also, they said that, sir, the videos, the surgical videos that you saw, that is required for particularly this presentation. Otherwise, the theoretical aspect and the explanation, chalk and duster is the most frequent thing for that. And again, I must say that it is an expectation effect. When you look into the students as a teacher, and I always feel, and I always wish also, my mouth should not speak, my eyes should speak. My eye contact with the students, that's a direct effect for that. And my eyes should speak and they should listen by the ear. And if that is so, they will grasp more for that. From classroom to bedside, we have in gynecology as a discipline, from descriptive learning to problem-based learning. This is very, very important. Not only for the clinicians, but for the students also. Problem-based learning is a very important, which is necessary for your delivery of the goods. From conventional teaching to simulation-based teaching. Now simulators have really aided to the teaching methodology. There are very few centers I have seen, very few medical colleges where the simulators are there. Simulators have started, the concept of simulation started from the West. Because there is no plenty of teaching material. The clinical material is very scant. Where from the students will learn? We in our age, you compare, you have got plenty of clinical materials. You can have patients, you can teach the laparoscopy or teach the conventional surgery over the patients, but they don't have. And therefore, the concept of simulation came. And that concept of simulation, because it is exactly simulating the live thing for that. But live surgery, live demonstration cannot be equated with the simulation. But if you do a simulation studies in a labor room, the delivery of the babies, the sonography, the endoscopy, and the various aspects, simulation, ICU, everything simulation can be done for that. And that is more close in the high-tech gadgets. I feel that simulation is also very, very helpful for that also. And this has become a part and parcel of many of the educational institutes now. And jack of all trades, master of none. I am a teacher who is jack of all trades, master of none. I do everything. As a teacher, although I was not very much interested in gynecology, I have to admit patients of ovarian malignancy and cancer cervix and do the Vardim or laparotomy for ovarian cancer for the students to learn. I cannot refuse that, yes, I will do only infertility, I will do only endoscopy for that. So therefore, we do all varieties with a special reference to something could be there also. So therefore, I have converted into jack of all trades, master of none. So I involved in all activities. I wish I should be jack of all trades and masters of all, where in this life it is not possible. I cannot excel other people for that, even if I try for that. My brain has a capacity for that. And therefore, this is my wish, this is my dream. Now the blending, the need of the hour is a blending. Blending of theory and practice, tech and touch, art and science. Because believe me, obstetrics and gynecology is so close to art and science. I must salute the person who has really found out most apt obstetrics and gynecology. I do not know who has coined this word obstetrics and gynecology. So apt. Tricks of obstetrics and logy of gynecology. Art of obstetrics and science of gynecology. I think this is something unique which I analyze and realize that. Efficiency and proficiency. The two English words has a different meaning. Efficiency. You do a technical job, finish that, it is an efficiency. But proficiency, our professional job is proficiency. A technician's job, a problem in the machine, corrects it. Efficient persons will be there. They will be called efficiency. But proficiency in a medical profession, it is more above than efficiency. It's a proficiency for that. Hard work and smart work. Another time, we are believers of hard work. We say that hard work is necessary for success. That's why we are doing unnecessary work which is not utilized, which is not productive also. That is also useless. We're not able to discriminate which is productive, which is beneficial, which is not beneficial. Just working hard for hours together. But now, the next generation, they believe in smart work. They don't believe in hard work. But at this juncture, I must say they are wrong. There is no shortcut to success without hard work, but a blend should be there, hard work and smart work. Both should be a blend for that. You should identify which hard work will not give you really benefit for that. Abolish that. But smart work is also necessary along with the hard work. Attitude. Attitude and aptitude. Attitude of a human being, you know that this is an attitude, good attitude, bad attitude. But aptitude. Aptitude is again a one level up attitude for that. At what level you are. And then you have a pains and pleasures. Believe me, pains and pleasures in obstetrics and gynecology. One day you find that you are successful, you find pleasures and pleasures. The next day you are toiling in the labor room, have a hectic PPH, not able to save the patient. The pains are there for that. So pains and pleasures both are there, and to enjoy that, this is our profession. Amidst pains and pleasures, you find out whether it's a painful pleasure or a pleasurable pain. And lastly, every professional should have a will and should have a skill. Will and skill is required for that. And if both are there, you can drill everything for that. So roles of a teacher is an information provider. Not only information, he's a role model, facilitator, assessor, planner of curricula and courses, creator of resource materials. Key competency of ideal medical teacher is an ideal medical teacher. Passionate, passion for teaching, response, integrity, character and integrity. Motivation is the power to motivate people, motivate the students. Creation of good learning environment. He should not only teach, the total environment should create in such a way that automatically the learning atmosphere will be there. And last but not the least, his leadership quality, and he should be a leader in that scenario for that. And passion for teaching and compassion for treatment, if is there, is a true doctor teacher. A doctor teacher and ordinary teacher is different, because a doctor teacher teaches and treats. So passion for teaching and compassion for treatment should be there. Attributes to a good teacher: he must have enthusiasm for teaching. He must be an enthusiastic personality. Understanding of the learner's specific needs. We should learn the need of the students, what is there. Understanding of the educational targets and mandates from national organizations, syllabus, universities, organizations, or thing that is necessary. Clinical and surgical competence in our faculty. Possession of knowledge, I have again emphasizing. Organizational ability, you should have because this is an academic organization. It's not a political organization. So academic organizational ability you should have it. You should have a good time management. That's very important. And time management is really important in all spheres, including ours. Ability to use different teaching methods appropriately. Ability to guarantee patients' privacy, dignity, and safety. So an ideal medical teacher is a facilitator of group learning, trainer of clinical skills, designer of interesting learning, master of good communication, survivor of daily challenges, follower of ethical code, class personality. Personality must be a class personality. Eager learner, ardent researcher, constant evaluator, technological witch, evidence-based medicine, and an effective tutor. These are components and characteristics of ideal medical teacher. Today, I inspire all the medical teachers across the country and the world that have a target on that, have an enthusiasm to be an ideal medical teacher for the sake of the medical profession, and more so the obstetrics and gynecology for that. What are the inhibitory factors? Inhibitory factors, there could be some inhibitory factors. Lack of time, lack of interest, lack of knowledge of the curriculum, poor level of familiarity with different methods of teaching, lack of familiarity with the learner, lack of continuity with the learner. These are all essential inhibitory factors for that. And this influences the mood of the teacher. You are all human beings. The mood of the teacher also as a human being, he has a mood, but he will not work as per the mood of himself. It is the need of the student. He should motivate and he should adjust with that, whatever inhibitory factors with that. That's the primary aim of a teacher. So hallmarks of a good learner, on the other hand, the students. Who are the good students? What are the hallmarks or quality? Motivation. He should be a motivated learner. He should be crazed to learn. Good communication skills and language proficiency. I think this is absolutely essential for both teacher as well as students. A teacher I have seen, there are many teachers who are voracious readers and pent up with knowledge, but they cannot communicate. The oratory capacity is not there. Teaching methodology is wrong. They're not good teachers. So a good teacher is one. Whatever I know, I must be able to transmit to the students for that. Then only you are a good teacher for them. You may be a good surgeon, but for the teacher, I think how much you transfer to the students is essential for that. If a teacher transmits 80% of the knowledge to the students, I think he's a superb teacher for that. The ability to understand and apply learning, the ability to retain facts, good time management, that's important. But unfortunately, teachers are very poor time management. Once they speak, they cannot, nobody, even if there's somebody wants that you stop it, you won't stop. And this is a particularly, I have felt it, and I am one of the examples for that. I'm a very poor in time management in the lecture session. Whenever I go, that 25 minutes has been given to me, I will be speaking. And particularly, this so happy our chairpersons, our audience is again giving me more time that you speak for that. That's a really bad thing. That's not a good thing for that. Time management should be there. But a teacher cannot restrict, and I cannot restrict once I start this. And therefore, many of my E-Gurukul session in 27 episodes you have seen. Initially, when the E-Gurukul episode has been designed, it was for 2 hours, 6 p.m. to 8 p.m. But I saw in one of the sessions there are 3.5 hours, 3 hours. Neither Juventus people, neither the Diwan or Alad stopped me in speaking for that also. And neither my viewers also stopped it listening for that. In that way, I'm a blessed personality for that. Potential pressures faced by learners. What are the pressures faced by learners? These are as inhibitory for teachers. The learners do have some problems. Lack of time. Yes. He's busy. It's such a busy 24 hours. He's busy in the department. Lack of time. You have to adjust the time with the work. Don't neglect your work and devote this for that. So lack of time. Failure to grasp the aims of the curriculum. There are some people who knows that yes, this is subject, but the curriculum is there. You have to learn in that manner. Otherwise, you do not pass. You may be knowing many things, but in examination, you fail. So first and foremost is to obtain a professional degree. And therefore, you have to grasp the aims of the curriculum, you do it. And according to the syllabus, you read it. And according to, suppose there is a theory question, you cannot write everything in that theory. Whatever is asked, you must mention particularly for that. Feeling undervalued. If you compare, there are 20 students in one batch, and everybody is different. And some students feel inferior, they're undervalued. And here the role of teacher is to find out those who feel that they are inferior, who feel that they are undervalued for that. And before you, everybody is same for that. Rather, you devote more time to the person who are undervalued for that. Facing competition, bullying, lack of understanding of assessment and documentation, concerns over proficiency in communication skills, and quality of life issues. Evidence based on science. These are scientific evidence, lab test about the learning methodology and the learning hours. It has been estimated that it takes about 10 years of intensive involvement and 10,000 hours of practice to acquire an elite level of expertise or performance. The word skill, which I mentioned it. You may have a skill, but how to acquire that skill? It takes about 10 years of intensive involvement and 10,000 hours of practice to acquire an elite level of expertise or performance. And as far as surgery is concerned, the time taken to achieve mastery of cognitive and manual skills in order to practice surgery is estimated to be 15,000 to 20,000 hours. So imagine if you are 15,000 to 20,000 hours in surgery, you can acquire an optimum skill for that. And the CCT may be a milestone, but it's not the end of the journey for that. Dear friends, to summarize the second component, interaction between teachers and learners in the clinical workplace is pivotal to medical education, and it is impossible without interaction. The teaching cannot be done without interacting with the teachers and students. Significant limits on time. Demonstration to the learner and observation of the learner must be followed by both evaluation and feedback. Several different teaching methods are used in different circumstances. Some teaching methods may be applied in a matter of minutes, others require application over several months. And the learners of today are the specialties who will care for women over the next 40 years. The teacher should believe that these students will go to the society and the healthcare of a woman will depend more of them. And therefore, it is my duty to see that a quality professional should evolve, quality gynecology should evolve from my institute for the benefit and welfare of the woman who can deliver the goods properly. And that should be the main aim for that. And therefore, again, I conclude that the need of the student is a priority over mood of teachers. Whatever inhibitory factors is there, whatever personal problems should be there in the teachers, I think you should look into the need of the student, and as per the need of the student, you have to adjust with that and do your job as an ideal teacher for that. So a mediocre teacher teaches on this auspicious day. There's been a lot of classification. It's not my quotation. It's an age-old quotation for that. And it's true. Again, for this truth, I'm again presenting this. A mediocre teacher teaches. A good teacher explains. A superior teacher demonstrates. And a great teacher inspires. I'm looking forward for teaching, for explaining, for demonstrating. But main thing I'm looking forward for inspiring. If I can inspire a student, my job is fulfilled. And my aim is fulfilled to become an ideal teacher for that. That's my ultimate aim, is inspiration and motivation. And this is my version. I always say, just remember, at the end of my introspection today, at the end of my frank confession today in the Teachers' Day 2022, I delivered these two words, two sentences to you. I cannot teach anybody anything. I can only move them think. To repeat, I cannot teach anybody anything, but I can only move them think. If this is done, my job is over. I feel that I am a teacher up to my desired limit for that, up to my desired ambition for that. And the Japanese proverb, again today in this auspicious day, better than 1,000 days of diligent study is one day with a great teacher. And that's really true on behalf of the learner or the student for that. Well, thank you very much for being with me in these two different fractions in this episode. The first part, second part, and the last part, the concluding part. With that, I will finish this particular episode. Mistakes I've done in my life, what are the lessons learned? This is the story of a gynecologist. मैं 12th में था, वो 12th में थी. मैं MBBS में आ गया, वो BSc में थी. मैं MBBS में था, वो MSc में थी. मैं MBBS में था, वो PhD में थी. मैं MBBS में था, वो डॉक्टर बन गई. उसकी शादी हो गई, मैं PG एंट्रेंस दे रहा था. वो 2 बच्चों का मां बन गई, मैं MD गायनी कर रहा था. बच्चे 5 साल होकर स्कूल जाने लगे, मैंने सीनियर रेसिडेंट कर रहा था. बच्चे 10th पास हो गए, मैंने हॉस्पिटल शुरू किया. अफसोस है ये कि आज उसकी ट्यूबेक्टोमी है और मेरी एंगेजमेंट है. Story doesn't end here. The journey continues with pains and pleasures, pleasures and pain. Mistakes. To err is human. Every human being does the mistake. And today in this auspicious day, there are two mistakes I have done, personal mistakes and professional mistakes. Many personal mistakes I have done it. I don't want to disclose this to you for obvious reasons, but I have done many personal mistakes. But professional mistake, I will tell today, reveal today, because from the beginning I told there is a frank confession of myself, mainly on a professional value, so that you enrich yourself and you gain something with that. It is said that there are three blunders in life. First blunder, to become a doctor. Second blunder, to select a doctor as a life partner. Third blunder, to create doctors as a progeny. It is by choice or by chance. I have done all these blunders in my life. I have become a gynecologist. My only wife is a gynecologist. And my only daughter is a gynecologist. And along with that, I have done fourth blunder also. My son-in-law is also a gynecologist. So many people have done, all of you must have done one or two blunders, but I have done four blunders in my life. It's by choice or by chance, I do not know. There are people who tell, very experienced people, professors, they say that I do not face complications or I have not seen surgical problems. I say either not doing surgery at all or that the greatest liars ever possible for that. So therefore, ladies and gentlemen, let's have a situation analysis and introspection, scientific analysis and action with confidence. These are all real life situations of mine. I have faced it. I will present before you for the benefit of you people for that. Therefore, I label it as a frank confession. I will not hide anything for that, even it's a silly mistake. I remember way back in early 80s or late 79, I was in postgraduate, first year postgraduate in SC Medical College. I was in duty in labor room. A patient came, Mrs. X, third gravida, para 2, both spontaneous vaginal delivery. Last child was 3 years back at 38 weeks of gestational age. Admitted to labor room at 9 p.m. where I examined it, and she was complaining of abdominal discomfort since 4 hours. On examination, uterus was tom size, contraction mild, relaxation good, fetal heart is 140 per minute. PV examination I did, cervix fully effaced, os fully dilated, membrane absent, head at 0. And whole night I observed, patient didn't deliver. A multigravida in second stage from 9 p.m. till morning, there was no progress. Patient has not delivered. So I give a call after 12 hours to the RS. RS came, did a PV examination, found that cervix is long, os closed, no abnormal discharge, patient not in labor, transferred to antenatal ward. It's a really, I felt very ashamed. Being a postgraduate, I was not able to see the dilatation effacement and telling that os is fully dilated when the os is closed, cervix is closed. I feel very ashamed of it. I told, since that time, I made it a point that this whole month in the labor room, my only agenda is to see effacement and dilatation. Otherwise, I will not learn anything for that. So I asked our lecturer, Madam, tell me how to see the effacement and dilatation. Then Madam easily explained that effacement is when the portio vaginalis of the cervix is gradually taking up. And dilatation, you introduce your 2 fingers in the vagina. If 1 finger goes, it's 1.5 centimeter. If 2 finger goes, it is 3 centimeter. I told then, if 3 centimeter, if 2 fingers loose, it is a 4 centimeter. I told then, if it is little loose, 5 centimeter, then little loose, then it will no science. How to know? You cannot introducing 3 fingers into it. Then I asked, Madam also confused. Yes, there is no science, little loose, it's just a guesswork. Then I referred all the books, I couldn't get anything. I wrote to all the editors then how to know? It is accurate to diagnose dilatation up till 5 centimeter through the cervix, through the os. But how to know beyond 5 centimeter? No reply came. Then I thought, let me think about it. Then I thought, up till 5 centimeter from inside, and after that, you can find the rim of the cervix which is left behind. That you can measure it, that you can approximate by introducing your finger, 2 fingers are there. How much is the rim which is left behind? And then find out a concept that 10 minus 2n, where n is the rim of the cervix which is left behind. If 1 centimeter is left behind, then the dilatation is 8 centimeter. If 2 centimeter is the n, then left behind rim is 2 centimeter, it is 6 centimeters the dilatation. Then I wrote to all the editors that this is the thing which I have got it from. At last, there is a book called Lange Publication in Obstetrics and Gynaecology, Current Diagnosis and Treatment in Medicine, Surgery and Gynecology. So the big book, they responded and they wrote to me that within this 3 months, the next edition, your concept will be incorporated in that book. 10 minus 2n, where n is the rim of the cervix which is left. I was so happy that I was frustrated from the beginning, and from this great blunder which I have made it, I got a lesson. And I got not only a lesson, I got a new concept. And therefore, this is a mistake which has taught me a lesson. Not only lesson, but other people are also benefited for that. Way back in early 80s or 79. So the message lessons learned is acquiring skill is the greatest wealth of a professional. And this skill acquisition is possible only by thinking for that. And a knowledge acquisition, a good guide is essential. You have to refer to the good guide. He can guide you in which direction you should go for that. Situation 2. Mrs. Y, 46 years. All LSCS, menorrhagic cycle for 1 year, obese, hypertensive, diabetes mellitus. I was an assistant professor in that time. A patient come to this OPD. Weight is 110 kg, pallor mild. For abdomen, I find obese parietis, wide scar. For speculum, cervix is healthy. PV, uterus antivated, normal size, far mobile, furnished free. So I just found out, and then I usually in the OPD, we examine and we dictate, the postgraduate writes in the ticket. The same thing happened. I just communicated, I dictated, the postgraduate, very sincere postgraduate, then according to the dictation, he wrote antivated, normal size, farm. Then she was very curious. She was a very intelligent girl. She was very curious and she requested me, sir, will you permit me? I will know what is the size of the uterus because I don't know how to elicit the size of the uterus. I told, yes, you can do it. And I said, then she explained how you do it. She said that, yes, put 2 fingers inside the vagina in the fornix and in the other hand in the suprapubic part, oppose and then find out the size of the uterus. If the size of the uterus is hen's egg, it is normal size. Then if it is more, 8 weeks, 10 weeks, 12 weeks, I just convinced him and described this. She introduced his 2 fingers and examined for 2 minutes. I told, what is there? You couldn't find anything? What is the size? Can you find out that the uterus is normal size? Then she replied, sir, I couldn't find the size of the uterus. I couldn't ascertain anything. Then immediately I thought, I also couldn't find anything. And as a convention, as a guesswork, I told that you write this. Antivated normal. It's not practically possible in an obese 110 kg women in a previous 3 cesarean to elicit uterus is antivated normal size. I realized I got a lesson from this, my postgraduate. This postgraduate taught me a lesson that there should not be any guesswork in gynecology. And since that time, I corrected myself. If I do not find the size of the uterus, I write uterus size is not elicited. Till today, I am mentioning that, and I remember that postgraduate. Because this is a guesswork. If it is not antivated, it must be retroverted. If it is not palpable, it is a normal size. And therefore, what's wrong and what's right? No guesswork in gynecology should be there for that. Situation 3. This was there when I was in periphery in a PHC, primary health center in the peripheral cadre. A patient came, second gravida, para 1, post-cesarean pregnancy. She is short-statured, 38 years, second gravida. And cesarean section was done for CPD 4 years ago in the district headquarters hospital, where I could find out the tickets. And the discharge ticket depicts that the indication of cesarean was CPD. Now on examination is a normal fetal growth profile, vortex presentation 5/5, estimated birth weight is 3.2 kg. We were at that time, sonography was not there, and we were in Johnson's formula, we were just calculating clinical sense, we are calculating that is a 3.2 kg. And normal clinical biophysical profile, because the Likert status and everything, clinically we just, and do a PV examination for the pelvimetry. Apparently normal clinical pelvimetry. And planned for elective cesarean section on 20th of July. I said that you are a short stature, you are a post-cesarean pregnancy, you are 38 years. And moreover, the indication of CPD was a recurrent, it is not a non-recurrent indication. And therefore, decided the date 20th July to do a elective cesarean section there in the PSCs. But unfortunately, to my bad luck, she went into spontaneous onset of labor on 19th midnight, hospitalized, spontaneous vaginal delivery, male baby by midwife weighing 3.3 kg without any maternal or fetal complications before I could reach. I felt ashamed. Is it a wrong decision? Where is CPD? Whether C, the cephalic is defective, or P, the pelvis is defective, or D, the doctor is defective. Most probably the doctor is defective. How to deal with these situations? The patient will lose confidence on me. That's a stand. The impossible delivery is not possible, and you have to do an elective cesarean section. We say that obstetrics is unpredictable. No, it's not unpredictable. Our booster antenna is not able to capture those. And multiple variables. Here, what are those? Pelvic assessment. Not only pelvic assessment. You have to find out that this particular head or this particular fetus will negotiate and pass through this particular pelvis. Then only you are ideal. And there is no measures now till we have developed technologically, we have developed since long. I was thinking. And from this mistake, I thought there is a lot of inaccuracies in our clinical sense. All the methodology which we have learnt it by Mundokarma method or by Donald method or head pushing test, whatever it may be, it is a retrospective. If delivery is there, then only we can say that this pelvis is optimum for this particular fetus. Otherwise, you cannot have any assessment criteria to know that this is accurate, pelvis is accurate for that particular fetus. And till today, I'm not able to find out any answer for that. I'm looking forward to find out a measure in spite of the radiological pelvimetry or clinical pelvimetry, whatever metry. The real pelvimetry and fetometry should be there in future to say that this fetus will negotiate and go through that. This is so dynamic for that. So message and lessons learned. Expect the unexpected. Assess and reassess always. Communication and counseling is important. And you have to counsel that previously. Otherwise, you would have lost confidence on you. You have to counsel. You have to ask that during the, if at all there is a pain, we have to again reassess during the time of labor, whether the head can, what is the situation there. And learn from others' mistake and gain from your mistake. If you learn from your mistake, you'll be doing mistake and learning, and whole life will be spent. If you learn from your others' mistake and gain from your mistake, then you can do something in your own lifespan for that. And ultimately, you have to introspect. If something hasn't happened, don't take it casual that obstetrics is unpredictable. It happens. No. What is wrong? Introspect yourself. And from that, you can think many things more than me. Mrs. X, 48 years with heavy menstrual bleeding for last 3 years. Para 2, both LSCS. Uterus was 16 weeks. Evaluated. Endometrial biopsy, simple hyperplasia. Sonographic evidence of multiple myoma uterus and incidental cholelithiasis, having multiple calculus. Now, in the era of minimal invasive surgery, we usually plan for a combined surgery, a joint surgery. A surgeon will do a lap call and I will do a lap hysterectomy. In a common sitting, that is very advantageous to the patient. In a single sitting, we can do it both financially as well as physically, mentally. This is all accepted, then decided. But this general surgeon requested me that let me do the lap call first because she has an engagement, other operations. And I usually agreed for that. Lap call was finished, and during the time of tissue retrieval, patient had an intra cardiac arrest. Hysterectomy was postponed. Luckily, patient was resuscitated and revived and discharged from the hospital after 3 days with the diseased uterus in situ for which she had visited me. It's totally embarrassing for them. So, from that I learned a lesson. Combined surgery for 2 pathologies in one sitting is not contraindicated. In the era of minimal invasive surgery, such procedures is beneficial to the patient. But I learned from this incidence that the principle should be take up the surgery first for which the patient has presented, not for the coincidental findings. The presenting features is a bleeding, hemorrhage and myoma. You should do first, then gallbladder they should do subsequently. Primary gravida, 32 years, conceived following investigation for primary infertility, 8 years, IVF conception. Husband is an IPS officer, wife is a journalist. Very terrible combination. Twin pregnancy, regular ANC, had bleeding at 11th week, treated conservatively. TIFA, normal scan, normotensive, admitted with preterm labor at 31st week. Hospitalized, given betamethasone, nifedipine, rest, repeat sonography revealed normal biophysical profile. Discharged after 1 week and counseled to undergo elective CS at 36th week. Initially, because of the condition, I counseled that let this patient be hospitalized for 2 weeks. But she told that I will come after 1 week. My house is there. I agreed that yes, after 1 week you come. But unfortunately, she was readmitted after 2 weeks. She didn't present with 1 week. That is at a 34th week she came with an episode of mild bleeding PV. BP was 140/90. Uterus tense, tender, FHS not localized, no active bleeding PV, urine albumin nil. And sonography reveals twin fetuses at 33.2 and 34 weeks and IUFD 2.2 and 2.4 kg. What wrong with the patient? Wrong with the patient is that she was callous that 2 weeks instead of 1 week, 1 week she went ahead. She took it very lightly. What's wrong with the obstetrician? It's not possible that all cases you admit it up from 34 weeks, from 32 weeks till delivery for that. Or you could have done an then and there cesarean section, delivering that baby at 32 weeks. You don't know the prognosis. You cannot equate that all cases of IVF should be delivered at 32 weeks. And what could have been done to save the babies and baby? And what next? So the message, IVF pregnancy is luck, but to have a baby is destiny. Even with the best practice, such things can happen. Prevention and prediction is $1 million question. Early intervention is justified, but only on retrospective thought. You cannot have a retrospective thought and do that. Obstetrics. Counseling, communicating bad news and after effect. Next pregnancy, possibilities and outcome is a big question mark for that. G3P2, placenta previa, transverse lie, previous cesarean. Placenta previa, transverse lie at 36 weeks, LSS was done. Male baby of 2.4 kg delivered with difficulty with fracture left femur of the baby, not of the obstetrician, and lateral extension of uterine incision with broad ligament hematoma, uterine atony, PPH, shock, patient resuscitated and saved with 3 units of blood transfusion. How to prevent? How to manage? These are all learning from lesson. Pre-op planning. I didn't have a pre-op planning. I think pre-op planning should be there. You have to identify what are the risk factors. It's a post-cesarean section. It's a placenta previa. It's a malpresentation, the transverse lie. And all cases may present with atonic and traumatic PPH. So from the beginning, you must be very plan your surgery that what difficulties I will encounter in that particular case. Patient is not in labor, lower range segment is not well formed. Placenta, whether it's a inner adherent placenta or not, that we do not know. That is a possibility also. You must keep it in mind. Senior consultants should be there in this particular crisis. Preventive surgical steps, tackling vessels before incision. If there are vessels, they present up avia, you just ligate proximal and distal and then give an incision for that. U-shaped incision on the uterus so that the uterine are not involved. Gentle delivery of the baby. And believe me, if it is a transverse lie, you have to identify, plan it beforehand, before giving an incision, that where is the leg and where is the hand. If the leg is there on the right side, you introduce your finger on the right side and then capture it. Otherwise, what happens? You push your hand and bring down the arm, then push it again, searching for the legs. So this is defective planning. Prophylactic ecbolics, and luckily we have got now a very potent ecbolics, carbitocin has come out. Pack, press and pray. I always say 3 P's: pack, press and pray in cesarean section. And don't do manual removal of the placenta always to finish the surgery quickly. You just deliver the baby, pack it, press it, and pray it. Then absolutely it will be dry and you must suture it for you. Active management of third stage. Recognize active bleeders, tackle separately. If there are active bleeders in the end, in the lateral margin, you ligate it separately rather than inclusive of the vessel, inclusive of the muscle, and you take in the angle for that. That's wrong. Optimum hemostatic closure. That's very important. Hemostatic closure should be optimum. And of course, peripartum monitor. This has happened again long decades before. 2.5 decades before. Primary gravida, 38 weeks in labor, planned for emergency cesarean section due to non-progressive labor. Delivery of the baby done with classical gymnastics. Normally, hand is introduced, ask your assistant to push it, fundal pressure. If fails, then 2-3 people will be there in fundal pressure and then delivering it. And I delivered it. And after that, extension of the uterine wound on left side involving the uterine extension to the lower uterine segment on right angle, repaired with difficulty, traumatic PPH, 2 units of blood transfusion. Now, what are the lessons I learned? How to prevent it, how to manage it. What are the problems? How to prevent it? Right technique of delivery of the baby is essential. And then I thought, no more these gymnastics. I will use the forceps. Then I applied forceps. There's a difficulty in application of the forceps because right cephalic application was not possible. I was really bothering about that, and forceps was not suitable for that. Then when the celastic vacuum came, I think I met Professor Vaskar Rao long back in one of the AI stages. At that time, there was the innovation of the celastic vacuum. And when the celastic vacuum came in place of metallic, I thought this will be an answer for that. And then lessons from that, delivery of the head by vacuum. For last 25 years, I'm using this celastic vacuum. You apply it half to the head and half to the scalp and half to the muscle. And then with the fingertip, you just separate it so that the whole of the cup will fit into the scalp. And then no gymnastics is necessary. Just with a little pull, the whole of the head will come. And this is the method in which easily it can be delivered with that. And since that time, I do it. I preach all and teach all my postgraduate to deliver the head, high head, low head, or mid head. If the head is there, this is the method we use it for that. So this is a lesson learned by mistake. Third gravida, para 2 L1. Previous 2 LACS. First is LACS torn male baby, could not be revived. Second LACS elective. Female baby of 2.9 kg living, only one living. Third, she wanted a second. Previous 2 cesarean. Third, conceived following investigation for second infertility. I done a tubal convolution, regular ANC, no risk factor, normal biophysical profile, color Doppler normal. Decision for elective cesarean was done on 18th February at 38 weeks. That was decided. The next day, the mother-in-law came and requested me and opted to want to change a date and fixed a time as advised by Baba on 20th of February. Instead of 18th February, 20th of February she planned. There is no technical hurdles for that. So I easily accepted for that. That yes, we'll do it on 20th February. But unfortunately, on 19th February, patient had one episode of mild bleeding PV. On examination, uterus relaxed, normotensive, FHS not localized, sonography demonstrated intrauterine fetal death. Your comments? What's wrong with the obstetrician? What's wrong with the patient? Wrong with the patient, the Baba and Mama. Muhurtam. What's wrong with the obstetrician? Easily agreed with that. But of course, no indications was there for emergency case. But here, from that day onwards, I remember. Accidents can happen, but it's a coincidence which is more painful for the obstetrician. Decision versus deviation. And from that day, I'm that. If a patient comes decided for an elective cesarean section, but 2-3 days before, she comes at dead of night with little abdominal discomfort. Patient is not in labor, but it decided for elective cesarean section. Little pain and patient is not able. I will not have a sound sleep unless I do the cesarean then and there in the night. And therefore, decision versus deviation, I learned from my mistake. This again when I was a postgraduate. Para 1 with jaundice, viral hepatitis, delivered a torn female baby by vaginal route with mediolateral episiotomy. There was a mild PPH, controlled with ecbolics, had continuous trickling of blood. Coagulation profile normal, uterus contracted, vitamin K given, blood transfusion 3 units was given. We know that pregnancy with jaundice, there are of course bleeding. So at mild bleeding of PB was continuing on second day also. So my professor came and round. He advised hematological profile repeated, normal, vitamin K repeat dose given. Then he advised a new drug has come, injection Botropus, you give it and continue blood transfusion. Because he told that yes, in jaundice this happens. PPH is likely to occur in jaundice and repeat dose of vitamin K you give it and just empirical Botropus you give it. I was a first year PG. And he advised, and after 2 p.m., the postgraduate can see the patients, routine hour, the emergency hour. So curiosity with my mind came. I thought, let me do a speculum examination to find out where from the bleeding is coming, whether from the os or something else. That curiosity gave me. I asked my sister, did a speculum examination and found a bleeding point which was just bleeding from the episiotomy wound, a bleeding point which was found. And I just put one stitch, stitched without informing the RS, and immediately the bleeding stopped. And patient was stable. Then my RS could know that this has happened. I told, don't disclose this. Next day when my professor came, bleeding controlled, it's a Botropus, unit drug. See how Botropus took the credit, but reality is something different. But my RS conveyed this to my professor. So professor called me to the room and congratulated me that yes, you are right, I am wrong. And what you want? I told, sir, I want to pass postgraduate in first chance. If you want to give me that much easy. But ultimately, patient has an uneventful recovery. But what's wrong? Wrong is fixed idea, dogmatic views and complacency. In bleeding occurs, particularly in jaundice. That was a fixed idea. So prefixed idea is fatal in medicine. Methodological treatment has its own place. And one has to learn from anybody. From this first year PG, my professor also learned this. 23 years, para 2 vaginal delivery, full-term male baby, Apgar score 8/10, had severe PPH after delivery. Ecbolics given, blood transfusion arranged, bleeding continuing, vitals falling. Decision for emergency hysterectomy was taken. And then the assistant professor in charge of labor room did a hysterectomy within no time, but still bleeding continues. So I was in the other OT, in the emergency, in the routine OT doing hysterectomy. She asked me, sir, you come, and the patient is not, the bleeding is still continuing even after hysterectomy. Then I left, I went there, put a speculum, and I revealed a lateral vaginal wall tear with active bleeding. It's an active bleeding from the lateral vaginal wall. I sutured it, but patient had a cardiac arrest and patient could not be revived. Is it a bad luck of the lady or a bad hands of the obstetrician? Then I thought, it's imagine yourself, introspect yourself. All PPH are not supposed to be atonic. That's a presumption. Brain should be active while hands are hyperactive. Guidelines has to be followed and introspection for future is required. Don't blame the luck, blame yourself. There is a lesson which I always tell you, that methodological investigations and treatment is a part. Don't presume that this is atonic PPH and I'll do a hysterectomy, it will stop. It's a traumatic PPH. It could have been right there in the labor room, it could have been managed by putting a speculum. If you were putting a speculum, the patient would have been saved, the uterus would have been saved for that. But here, uterus is not saved, patient is also not saved. Mrs. F, primary infertility 5 years, plan for DHL. So, and this is the hysteroscopic view. You find a DHL has been done, 5 years infertility. When I put a hysteroscope, you find a particular atypical finding, a gestational sac, a pregnancy, and then more so I can find the embryo in that. 5 years infertility, doing DHL for infertility, I find a pregnancy, and the last menstruation, she tells that 10 days back it was the last menses. But it's not the last normal menstruation, it's just a spotting. So this is a very important thing. You take absolutely a history for that. Then I prayed God, I get tons and tons of progesterone, pregnancy continued, uneventful antenatal and antepartum, intrapartum period, male baby doing well 4 years back. God is great. And miracle happens at times. This is a miracle, but miracle doesn't happen always. And therefore, take a detailed history. If they say that menstrual history is 5th of July, you confirm that whether this 5th of July menstrual history, the same amount of bleeding is there as per June or not. Whether the last normal menstrual history, that is important for that. That is a routine thing which I'm maintaining. Mrs. X, case of RPL, plan for diagnostic hysteroscopy and cavity evaluation. Now you find something different. And this is a thing which I've seen that, yes, it has gone to the posterior part and a synechia. It is diagnosed that, yes, it's a synechia. But when I find that this is in the upper part, there is a black hole, which is that. This is absolutely looking like a synechia, complete synechia. And now in the upper part, there is a black hole. I ask that you depress the hysteroscope and the trainee depress the hysteroscope and then negotiated with that anteriorly. And then you can find a normal uterine cavity. Can you see the normal uterine cavity? The bust. So these are some of the mistakes which you do it. And this mistake, my student told that, yes, I will never forget this type of thing and I will never do this mistake again. And the alternative option, you do a vaginal vaginoscopy. Do a vaginoscopy, see the external os, don't catch the cervix, don't dilate, and introduce it through the external os and negotiate it, go through the cavity and evaluate and see the beautiful uterine cavity for that. Can you see that this is cervix, the cervical canal, and then this is the thing where the beautiful cavity is being seen with the two ostium after crushing the internal os for that. So this is an alternative for that. The cavities can be evaluated, hysteroscopic, vaginoscopic evaluation. So these are how to prevent. The message learned is improper dilatation is the factor. Visibility and orientation, change of direction of scope, double channel seats, and gentleness with negotiation without a resistance is the key. And you can use the misoprostol routinely in all cases also. No additional treatment is necessary. So routine misoprostol or vaginoscopy. This is another para 2 previous cesarean, previous history of myomectomy with abnormal uterine bleeding. Uterus 12 weeks with myomouterus, plan for vaginal hysterectomy. And after during the closure that, I find that there is a brinjal seed. Where from the brinjal seed will come to the pelvis. This suspicion, and then I searched for the rectosigmoid. I found a small rent. And no fecal matter is coming. It's a prepared case. And I just detected repaired vaginally for that. So these lessons, immediately early recognition of this particular thing has shaped me for that. So rectosigmoid injury can occur in vaginal surgery. Detection is vital. Repair in the same sitting is feasible. Post-op result on satisfactory, and meticulous technique is the answer for that. This is again 38-year-old, history of progressive dysmenorrhea since menarche. Laparotomy done at the age of 16 years for bilateral chocolate cyst ovary. Relieved for 6 months only. Taking analgesics off and on. Married at the age of 20. Investigated for infertility. Laparoscopic surgery twice. Persisting pain. Ureteric stenting for 3 sittings. Persisting pain and infertility. IVI 6 sittings. IVF 3 sittings. Progestogens, danazol, GnRH analog, Depo-Provera for years. Presenting with severe pain with adenomyosis and chocolate cyst ovary right. Planned for laparoscopic hysterectomy. Conversion to laparotomy because everything is pasted. Hysterectomy with bilateral sulping oophorectomy at the age of 36 years was done. They were relieved of symptoms for 6 months only. After 6 months, she developed severe dysphagia with pain in right iliac fossa. On examination, endometriotic nodule in the vault and posterior fornix with cystic lump in the right fornix. Endometriosis is not leaving this patient. Sonography revealed residual endometriotic cyst with evidence of vault endometriosis, not relieved with medical management. From Pati to Pati and Bhavas to Mamas, attempted suicides twice, rescued, decided for surgery with colorectal surgeon. Excision of the cyst and rectosigmoid lesions and ureteric dissection with stenting and colostomy was done. Closure of the colostomy after 3 months was advised by the surgeon, and unluckily on 4th post-op day, due to blood transfusion reaction, patient expired. He's an unlucky patient and unlucky gynecologist, born with pain and died with pain. It's a preventable death. One, the blood transfusion was not required at that time. She was comfortable with that. 1 unit of blood can easily take a life. And that lessons learned. Restriction of perioperative blood transfusion. And since that time, unless it's a too critical a situation, patient is bleeding and life and death situation, multiple units of blood transfusion you give it. In oncology, give it liberal transfusion for that. But routinely, wherever avoided, I usually avoid transfusion. Rather, give it a parenteral iron for that. So preoperative planning and preparation. And 1 unit of blood can easily kill a patient. Those require blood, they require more than 1 unit of blood. So transfusion phobia, benefits and risks and all that. It's really a phobia for me after this patient for that. 45 years old, P2, both LSCS, known case of pelvic endometriosis with adenomyosis. Previous history of lap surgery once and laparotomy once. Hysterectomy could not be done. Referred case with persistent pain and bleeding, planned for e-surgery after 6 weeks. Hysterectomy with bilateral sulping oophorectomy could be done in spite of plastered pelvis and non-visualization of anatomy. Left ureter avulsed, detected, and ureteric implantation to the bladder done. Post-op eventful, uneventful. I learned ureteric anastomosis by the urologist, from this case onwards. And then I think there is a learning from mistake. Everybody should learn. So ureteric injury, real panacea for gynecologists. Preventive surgical techniques is mandatory, but learning cysts. From that day, I learned cystoscopy, I learned ureteric catheterization, I learned ureteric implantation, and this I believe there is a must for gynecologists. Now I'm learning endoscopic, laparoscopic ureteric implantation to the bladder from the urologist. Learn from urologist and do it yourself. Therefore, building confidence in pelvic surgery for that. These are all small cases where bladder injury, I need not put that. Bladder injury, you can prevent it. And if it is there, you will make a lesson that yes, ureteric orifice, you find out, and then have a watertight closure and drainage, that will be all right for that. This is a very old case of mine when I was there in 1980s in CHCs. Mrs. X, primigravida, torn, presented with a deep transverse arrest. Planned for emergency LSS under local anesthesia. I tried with the local anesthesia, baby delivered, and mother had severe hypotension, bradycardia, and cardiac arrest. Cardiac message was done by the other doctors. Pressure agents was given. I was really confused. Hydrocortisone given, could be revived. When the patient is revived, then I thought I will finish it, the closure of the uterus immediately, and tried to finish the surgery as fast as possible. And then I closed it, single layer closure, I did it. Patient could be resuscitated, uneventful recovery. Then I realized, when after 20 years, the single layer closure was coined by the new technology for that. I was reminded 20 years back, my first case where I did this, the single layer closure, without knowing the concept of that, just for the sake of the saving life of the patient, I did it. So such surgical complications is not uncommon. Managing the general condition as well as completing the surgery during classic crisis single-handedly is a challenge. Concept of singular closure, personal experience, long before the emerging concept came. Second gravida, para 1, post-cesarean pregnancy, presented with impending rupture uterus, laparotomy done, moderate hemoperitoneum, dehiscence of scar, asphyxiated male baby delivered, could be resuscitated. But the repair of the scar with hemostasis was done, peritoneal toileting done, uneventful intraoperative period. But because the patient has a rupture uterus, requisition for blood, 2 units of blood has been given to the patient's attendant. And patient's attendant brought the blood. On second post-op day, hemoglobin was 7 gram%, but patient was stable. And I told that don't use the blood, don't transfuse the blood because of my previous experience. And patient's husband but insisted that I have brought the blood, you must give it, blood transfusion. So our 1 unit of blood was transfused, severe blood transfusion reaction, hematuria, shock, patient died after 12 hours for that. And therefore, again, I tell everybody that 1 unit of blood can kill a patient, and therefore restrict blood transfusion in obstetrics gynecology. Unless it's a life-saving measure, you do not ask for routine casual blood transfusion for that. Those cases, the hemoglobin can be revived with the normal. Even pre-op preparations also, AUB, fibroid, menorrhagic cycle, 7 gram hemoglobin. Many people build up the patient with blood transfusion. No, it's a wrong procedure. You arrest the bleeding by hormones and do, I think, wait for 1 month, give parenteral iron, and then hemoglobin can be brought up to normal level, build up, and then you can do a surgery for that. Mrs. X, 96 kg, previous CS with mama uterus and cholelithiasis, planned for lap hysterectomy with lap call. Uneventful intra-period, third post-op day, patient had breathlessness and chest pain. Tachycardia and tachypnea, decreased saturation, transferred to ICU. Diagnosed as pulmonary embolism, ARDS, heparinized, could be revived after 10 days of hectic stay in ICU. So message, such things not uncommon. Role of prophylactic low molecular weight heparin, routinely in OBGYN and obstetrics. From that day onwards, I made a rule that if the patient body weight is more than 90 kg, either in cesarean or in any pelvic surgery, routinely low molecular weight heparin for 5 to 7 days perioperative is mandatory for that. And believe me, it has paid in many, many situations for that. Mrs. X, 52 years, para 2, multiple myeloma, 14 to 16 weeks, planned for vaginal hysterectomy. Successfully performed. This happened just a few months, 2 months before, last month. Discharged after 3 days. And presented after 7 days with passage of fecal matter through vagina. At this age, I was really frustrated. She was a known patient of mine, educated. On examination, I find patient was stable, afebrile, abdomen was soft, bowel bladder normal moving the bowel. But post-speculum examination, I find frank fecal matter, rectovaginal fistula. I did a sonography, no intra-abdominal collection, hospitalized, prayed to God, surgical consultation was done. And surgeons also agreed that if there's, and then we both decided for surgical intervention. If altered abdominal signs will appear. If the abdominal signs will be there, we will intervene. Or after 3 months, if the RVF is not controlled, then we'll intervene for that. And therefore, she was convinced, and he stayed in hospital with observation antibiotics for 3 days. And after the 3rd day, discharge was reduced. So I told that it will be little inconvenience to put the pantry and pad with that, but we have to wait. If there is no abdominal soft, bowel is moving, and we wait for at least you come after 2 weeks, wait for 6 weeks, and then if it doesn't control, I will do the surgery for that. But she came after 2 weeks. Helen Hutty, no discharge, abdomen soft, bowel bladder normal, put a speculum on examination, vault was healthy, no discharge for that. So God is great. I'm a lucky surgeon with a lucky patient. But the message which I got it from that, there is a place for conservatism in this type of cases. I have found many cases here also. Not only this case, another 2-3 cases I have seen. Conservatism can help. And at the time of intervention, suppose if it's an abdominal signs, peritonitis and all that, you have to interfere. But if everything is normal, leave it as such. And ultimately, God is there to help. Para 2, 46 years, both LSAs, abnormal uterine bleeding, not relieved with medication, planned for lap hysterectomy. Lap hysterectomy done, dense adhesion of bladder successfully performed, uneventful post-op period, discharged. Presented with urinary incontinence after 10 days, diagnosed as VVF, cystoscopy done and rent was seen. So we planned for lap VVF repair with urologist after 6 weeks. Indwelling catheter was given and catheter removed after 4 weeks. Urine leak persisting along with normal voiding, and therefore already 4 weeks after 4 weeks also urine leak was there, and that's why I advised to come after 2 weeks for repair. 6 weeks after that is repair. But unfortunately, patient had a Colles fracture, and therefore she told that I have to wait for another 4 weeks. So another 4 weeks we deferred for another 4 weeks. But she came after 4 weeks, came for post-op checkup, no leak, bowel bladder normal, patient happy. I am also happy for that. I don't know how to explain this. What is the message? Spontaneous healing is possible. God's blessing and patient's destiny. This is another case. Mrs. Y, 30 years, conceived following investigation for primary infertility, 7 years, following hysteroscopic annulation and ovulation induction. Patient conceived, twin pregnancy, regular ANC, uneventful antepartum and intrapartum postpartum period, with the 2 healthy female babies born, discharged from the hospital. But after 1.5 years, I got a notice from the district consumer. This is the first case in my life. I don't know what is their first and last, but it's the first case in my life. And notice from the district consumer court for 5 lakhs compensation for maintenance of second child. I wanted 1. Why twin is there? So for the second child, I want 5 lakhs compensation. Later, I found that one of the relations advocate friend has blackmailed me and they required some money. I told nothing doing. I will fight it for that. And my petition was there that I will fight alone in presence of my counsel, and the whole proceedings of the court should be recorded, live recorded, video recorded for that. But unfortunately, the case was dismissed without admission by the district consumer court because it's a silly and malafide ground. And the judge told that if you're not able to maintain the second child, give to me, I will maintain that for that, and rejected the case. I was very happy. Doctor was, I'm really relieved after, but the mental stress of around 3 months, without any reason, 3 months. Patient is infertile, you have done treatment, twin pregnancy. She will file a case that I wanted 1, why 2? But 2 months after again, I was relieved. But again after 2 months, I again received a notice from the State Consumer Forum regarding the appeal by the party in the higher court. He gone to the higher court. Again, I was depressed. Exactly after 1 week of this received the letter, I was informed by one of my known person that the said petitioner met with an accident, road traffic accident, and died in the spot. And his only elder brother, who is a cardiac patient, who came rushed to see his brother, and when he saw the brother dying in the road, he also felt cardiac arrest, and both the brothers died in the spot. And the wife of the patient petitioner was crying that because you have done this thing to the doctor, the God has taken revenge on me. And I felt very bad that God has taken revenge on my husband for that. And I really felt very bad for that. And since that time, all the advocates know these incidents, and they are very afraid of me. That's a good point, that all the advocates are afraid of me, that don't go, case will be there, God will be taking revenge for that. So medical legal cases at times happens to be a case of blackmailing. If you do not maintain, remember one thing, I have learned a lesson from that. If you do not have a malafide intention in treatment, God is going to help you. You can have a morbidity, you can have a mortality. You are not a God to save every patient for that. But if you have don't have a malafide intention, whatever may be the situation, God is going to help you. Remember this, and you can't give an assurance that I will do everything right and I will save every life for that. This is not possible. So God has been too harsh in this case, and the doctor cried and prayed to God. This is Mr. Alad, your case. It is not Juventus. In AICOG Bhubaneswar, I must tell one thing. One of the multinational company, not you, pharma company, discussed regarding the sponsoring of the events, laying down certain terms and conditions, and promised for I was negotiating as a chairperson, 65 lakhs in total. And I have to give 5 commitments for that, 5 different activities. On the second day of the conference, 2 out of 5 of the promised events could not be done satisfactorily. So 3 could be done. 2 of the events could not be done due to some unavoidable reasons. And then for which the chairman of the company was very aggrieved and wrote a very nasty letter to me that on such and such date, our people went there, you promised that. On such and such date, we handed over a check of 65 lakhs. You took it. You promised to give 5 commitments, 5 different aspects, but you failed to provide the 2 commitments out of the 5. And if this thing will happen, why the pharmaceutical company will sponsor the conference? And we didn't get any mileage, for which we are very sorry on you. And we henceforward, we are not going to participate in any of the gynae conference for that. So I called the executive body, the organizing committee, and showed this letter to the executive committee. Everybody told that already 65 lakhs has been received by you. Just tear this letter and throw into the bucket. I told, no, I will not do that. It's a very nasty letter. I will not do that. I will have a reply. Then I replied. Then they agreed. Then a reply to the said letter was drafted by me against the will of the organizing committee. And there I wrote, dear sir, I received whatever the letters with reference to the letter which you have sent it on such and such date. From the beginning till the last, there is no falsehood. There is 100% truth in it. And I made a mistake. I feel that I admit that I have made a mistake for which you didn't get a mileage. And it is because of some reasons, unavoidable reasons, I cannot give you. But ultimately, I admit that I have done a mistake, so that I have not done this 5 activities out of it. And for that activities, because I failed to fulfill the commitment of these 2, I enclosed a check of rupees 35 lakhs as the committee has failed to fulfill these 2 commitments. And the organizing committee told, no, 35 lakhs we cannot refund. I told you have to respond. I have brought the money and you are responsible. You have to sign it. And I signed it. Another treasurer signed it, and we referred with all hesitations of the organizing committee. I referred that with the letter, with the check. Believe me, after 10 days, I received a letter from the same person. He was a Swedish man, chairman. And he wrote that with 38 years of profession in pharma industry, I am seeing for the first time a doctor admitting its own mistake from the beginning. This is something which is unique. I've never found across the world. And for this gesture of yours, I think I get a salute to you people. Instead of scolding me, he saluted me. And he told that again, no, it's our mistake. Our people should have gone and reminded that all that and everything is done. And for this gesture of yours, I am sending back this 35 lakhs check to you. And last sentence he wrote, and for this gesture of yours, admitting your own mistake, I am again enclosing 50 lakhs of check to you people. And that will be utilized for that. And I showed to the organizing committee a phrase of 50 lakhs additional, we got it in addition to 35 lakhs. And I again wrote a letter that this is not an AIShoji money. This is the conference money. I will spend this amount. I had fixed in a fixed deposit in different account and spend it for years together for that. CMEs every month for company purpose for that. So therefore, mistakes by human being is norm, but admitting the mistake is really a boon. And you learn that. I have learned that you admit, if you have done a mistake, admit it. Fulfilling the commitment in such event is a priority for that. You have to fulfill, otherwise you repay that. And always under promise and over deliver. Don't over promise and under deliver for that. This is the message to the pharma people for that. Alan Saab. And therefore, learn from others' mistake and gain from your mistake. And introspect, critically analyze and update all the time. Practice makes a man perfect. Yes or no? It's yes. No, it's no. It is a perfect practice makes a man perfect. You find out a perfect practice that will make you perfect for that. And the last words, my profession continues to be one of the best professions in all centuries, past, present, and future. Amidst pains, pleasures are there, ethical, moral, and human, amalgamation of head, heart, and hand, amalgamation of art, science, and commerce. And therefore, we are the winners. And then I can say today, at the juncture of the second anniversary of Juventus E-Gurukul program, as a teacher for the last 48 years, I am really a satisfied soul as a teacher, but giving a message that ultimately standard care is necessary. Where from the standard care will come? It is from right decision. Where from the right decision will come? From experience, right decision will come. And where from experience will come? It is from wrong decision that experience will come. And therefore, read less, think more, talk less, work more, have will, update skill, target scientific development, acquire human development. This is the message on this auspicious day of Teachers' Day to all of you, my viewers, my students, my fellows, my teachers, and grand students also. Then only you can have pleasure in body, peace in mind, and bliss in soul. Thank you very much, all of you, for giving me this opportunity for that. And that's all. Again, prayer to God for teachers. This Teachers' Day should be auspicious. Have an introspection, both the teachers and students. Then only the teaching can continue in a right way. Thank you very much.
Dr. Saab,
It's not, I couldn't hear.
Dr. Nawale.
ये कुछ स्विच से बंद कर दीजिए ना. म्यूट है नहीं, अनम्यूट.
Dr.
Hello.
Dr. Saab, unmute yourself.
Okay.
Yeah.
Okay, thank you. Thank you very much, sir, for a very knowledgeable and informative lecture. And this will definitely inspire the young minds in the field of gynecology. And on the occasion of this Teachers' Day, I have a quote for you, sir. It's a Japanese proverb, and it suits you, actually. The fact that you worry about being a great teacher means that you already are a great one. And thanks for being such a great teacher. Happy Teachers' Day, sir.
Thank you.
And happy second anniversary of this E-Gurukul series for all the viewers and doctors who are attending and who are also subscribing for this channel. Thank you very much, sir.
Thank you. Thank you.
And thank you, sir. I will read the messages and the questions for you. There are number of congratulatory and happy Teachers' Day wishes for you, sir. Just I will read the names of the doctors and the place. Can I, sir?
Thank you. Yes.
Okay. Dr. Niladri sent for from Durgapur. Dr. Upendra Kumar Oli from Haldwani. Anita Raja from Noida. Kavita from Indore. Dr. Ramani Rao from Chennai. And Haraprasad from Cuttack. Anit Kaur from Hyderabad. Sumitra Chauhan from Pilkua. Dr. Madhumati from Raigad. Dr. Sumitra Chauhan from Pilkua. So these are the few entries.
Thank you. Thank you. Thank you very much.
Thank you, sir. Thank you very much.
Thank you. Thank you.